Vein stenting in the context of acute iliofemoral DVT, and this is an example of a lady who presented with severe edema of the left lower extremity. She had a duplex which showed occlusion of the left external iliac and common iliac veins, and she underwent catheter-directed thrombolysis. And this is a venogram which shows total occlusion of the left external iliac and common iliac veins with a recent thrombus. The thrombus was crossed with the catheter, and this image shows a patent inferior vena cava. Then she had a thrombolytic catheter placed into the external iliac vein, and she underwent thrombolytic therapy. She was followed up by ultrasound until the thrombus was completely lysed. And this is the completion image, which shows total lysis of the thrombus, but it also shows lots of collaterals. And those collaterals indicate the presence of a chronic lesion with the acute lesion on top. A more proximal venogram shows the occlusion of the proximal common iliac vein. Those venograms were taken with the patient prone, so this is the left side. The patient was then turned over to a supine position, and direct access was obtained onto the femoral vein. And this image shows a venogram of the left external iliac and common iliac veins with total occlusion of the proximal end of the common iliac vein. This lesion was treated with a large balloon, and you can appreciate how the lesion was very tight looking at the waist of the balloon. And as you might expect, balloon angioplasty alone is not sufficient. She had an immediate recoil, and then she underwent a stent, and the stent was dilated, giving an excellent flow into the inferior vena cava. This is a typical example of iliac vein compression syndrome presenting with acute iliofemoral DVT. Iliac vein compression syndrome was first described by May and Turner in 1957. But it was Cockett and Thomas who associated this syndrome with acute iliofemoral DVT of the left side in 1965. We reviewed our series of patients treated for acute iliofemoral DVT using catheter-directed thrombolysis for the past 10 years. There were 62 patients, and 18 of those required iliac vein stenting. There were a young group of patients, mean age 34, slightly more females than males, minimal comorbidities because they're mostly young patients, mostly left side, but iliac vein compression syndrome can also occur on the right side in rare cases. This is our protocol of thrombolysis. We always obtain access into the popliteal vein using ultrasound guided. We use the wire crossing test to know to assess the thrombus and know if it is soft enough for lysis or not. So if the wire crosses, we go ahead with thrombolysis. If the wire does not cross, we terminate the procedure at this point. Then we determine the proximal and distal extents of the thrombus, and then we insert a thrombolytic catheter with multiple holes, and the holes should cover the whole length of the thrombus. And we inject TPA using the pulse spray technique. We use our old protocol of half an hour intervals. We follow up the patient with duplex ultrasound twice a day, that's every 12 hours, until the thrombus is completely lysed. And then we perform completion venogram to document the result and also to assess the iliac vein for stenosis. And if there is stenosis, we use a stent. Here are some technical tips for iliac vein stenting. We access the left common femoral vein or the affected common femoral vein by duplex guided puncture. This is important to avoid hematomas in those patients who are on anticoagulation and thrombolysis. We use multiple fluoroscopic angles to identify the exact location of the stenosis. Then we cross from the external iliac vein, common iliac vein, into the IVC using the loop of the wire, not the straight tip of the wire, to avoid going into a collateral, and there are many of those. We always use self-expanding stent, 90-node stent. We use large stents. This is important to avoid stent embolization, 14 to 60 millimeters. Long stents, at least 60 millimeters in length. And we position the stent with the proximal end into the inferior vena cava so that the lesion would be centered over the stent. We use large balloons from 12 to 16 millimeters according to the caliber of the common iliac vein. And the patients are always anticoagulated for at least 6 months after the stenting. Here are our results. Technical success 100%. This is expected. It's an easy, straightforward procedure, and it should always work. We had one case of stent embolization, but the stent was retrieved and fixed into place using another larger stent. We had 2 early occlusions in hypercoagulable patients, but the majority of patients remained patent for the whole length of the follow-up, and the follow-up extended from 6 months up to 10 years with a mean follow-up of 2 years. Really, after a while, the patients stop coming because they have no symptoms. Mudgil reviewed the literature of iliac vein compression syndrome presenting with acute DVT. There were 6 studies comprising 113 patients, majority females. The technical success was very high, 95%, but also the patency at 1 year was high, 96%. Raju and his colleague reviewed all the iliac vein stents ever published in the literature until 2013. There were 1,500 patients with iliac vein stents for various reasons, negligible morbidity. The patency of the stents for non-thrombotic disease was excellent at 90 to 100% at 3 to 5 years, but even for thrombotic disease it was very good, 74 to 89% at 3 to 5 years. Finally, Mr. Chairman, I would like to present this dramatic case. 35-year-old female presented with acute right iliofemoral DVT. She had multiple risk factors for DVT, but importantly, she had the left iliac vein stent performed 10 years ago in 2005. And these are the venograms, right-sided iliac vein obstruction. She had catheter-directed thrombolysis with complete lysis of the whole venous tree. But look at this interesting image. The right side was lysed, but I'm not sure if you can see here, the left iliac stent was patent. So when this lady who had 10 years ago a left iliac vein stent, when she had risk factors for DVT, she did not have a DVT in the stented vein, but on the other vein. It's a dramatic example which shows how durable those stents are. In conclusion, Mr. Chairman, iliac vein stenting for iliac vein compression syndrome complicated by acute iliofemoral DVT is a safe procedure with excellent long-term results, given good patient selection and attention to minor technical details. Thank you.